Life is a miracle. Life is a battle. Life persists against all odds. In South Sudan, life is defined by war. Generations of children have been born into violence. Millions have been displaced, still searching for home, still waiting for peace. It is the youngest country in the world with the largest humanitarian presence and staggeringly high maternal mortality. Here lies the whole horror and beauty of human existence. It's one of the most difficult and dangerous places to be a woman.
My name's Nwayr. I'm a South Sudanese. I was born in Uganda in a refugee camp in 1968. I trained as a nurse. I worked for around 10 years. From there, what motivated me to become a midwife was the mortality rate of mothers and babies in the country. The death rate of mothers in South Sudan was too high. So the initiative of training midwives had to begin. In 2006, they opened a national training school for Kajokeji. It had 3 classrooms, a dormitory for boys, dormitory for girls. We were about 105 students, and then there was problem of insecurity in Kajokeji. There was a lot of gun shootings. The community had all run away. We decided to move away from the school. All what we had were left behind. We only secured lives of people. I had 2 things to decide on. I had a family, which is my biological family, and I had a family which was the students. But I had to sacrifice my life and let the children go with the father to the refugee camp, then made sure that I moved with the students to come to Juba. It comes easy to insert into the vagina. When we arrived in Juba, we rented a place for the students. It's not designed for a school. So we have the rooms enough for their accommodation, but challenge is the classrooms. We do not have any item for skills lab. So the situation now is not the best, but at least it has kept us going. This school is not helping me alone. It is helping the communities of South Sudan, and it is improving the health of South Sudan in general. The outcome of the students that we have trained have motivated me so much.
So as a midwife, your role is to take care of a woman since from the day she got pregnant until the day she delivered, and 6 weeks after delivery. You make sure that you give her the necessary care you can able to give her and save her in case if there's complication. If I'm the one who conducted delivery, my baby is saved and the mother is saved, I myself even will be more happier than the woman who gave birth. Because I've saved life and I've welcomed what? Life into the world.
Currently, we are having 3 classes of diploma midwives training. Students come from all over the country. So it's a national training school. My students are united. They feel they are one.
Our life to see peace, and I would love to see if our women are really staying in a peaceful environment and they can able to educate their children without any interruption. So that's what we are hoping for.
I believe only one time the communities will come back, then these trained people will go and work on the communities. The more midwives we have, the more opportunities we give to our pregnant mothers, and the more life we give to our babies.
This is a place with so little, by so many measures, with a future so precarious and paradoxically so wide open. They don't have peace yet. But they do have grace.
Le cauchemar de tout docteur, c'est de tuer son patient. La maladie du sommeil, ça fait peur, parce que la maladie du sommeil, vous voyez ces signes d'agressivité. Vous avez les signes de quelqu'un qui devient fou. La maladie du sommeil ou la trypanosomiase humaine africaine, c'est une maladie infectieuse parasitaire parce qu'elle est transmise par la mouche tsetse.
The fly injects a parasite that circulates, goes into the blood, the lymph nodes, and later on will go in the central nervous system. And then eventually, if they don't have treatment, they will fall into a coma and die.
The last decades of the 20th century have been very productive in terms of new treatment, but nothing happened for those very neglected populations. Personally, when I was working with MSF during the 80s, 90s, I was confronted to a situation that was particularly dramatic, because the only treatment available to treat sleeping sickness was melarsoprol, an arsenic derivative, killing 1 out of 20 of patients because of toxicity.
It was described by patients as fire in the veins.
Dans mes prières, j'ai dit, Dieu, est-ce qu'il n'y a pas moyen d'éclairer ces chercheurs pour qu'ils trouvent un médicament facile à prendre pour soigner ces gens qui meurent, ne fût-ce qu'un comprimé.
The first step has been to improve the situation with a combination of nifurtimox and eflornithine called NECT.
So this is NECT, and all this is for one patient.
Le NECT, c'est un bon médicament, et très efficace et qui guérit plus facilement. Mais c'est la logistique qui est lourde parce que c'est fait, il faut transporter ces cartons et l'amener dans le milieu où il y a des malades. Souvent ils sont dans des forêts, ils sont dans des villages.
This treatment is available only for the second stage of the disease, so you need to go through a very difficult and painful lumbar puncture that every patient needs to be confronted with.
Ceux qui viennent à l'hôpital, on est obligé de les garder parce qu'on doit contrôler la perfusion. Ça doit se donner en intraveineuse.
And the consequence is we wanted to have an oral treatment to treat all the stages of the disease. So we started our research on this field with a basis that one class of drugs, nitromidazole, was having an effect on this sort of parasite. So we have organized a data mining of all the different compounds of nitromidazole coming from university, coming from pharmaceutical company. One presented the characteristic of what we were looking for, a molecule that was called fexinidazole, and it was developed during the 80s and abandoned because of lack of interest of developing a product for parasitology.
Sanofi had the molecule, but we partnered with DNDi, who brought their experience from preclinical research and being able to do the clinical trials in these very difficult to reach areas.
We started the study in 2012 in DRC and Central African Republic. It was incredible to have to think about how you would do sophisticated clinical research in an unsophisticated setting.
La RDC est un grand pays et la logistique elle est lourde.
There was poor infrastructure, lack of scientific lab equipment, no one trained on doing clinical research, and the political instability in these regions. To overcome these challenges, we had to bring electricity. We had to bring microscopes. We also brought some technology like internet and satellites to make sure we would have the connection. We did training of 200 people in good clinical practice, in pharmacovigilance, to make sure that they could comply with what is needed to have a new drug registered according to international standards. We supported the national programs with cars, with boats, to go and look for patients. We work with the best teams, those that know how to diagnose these patients, those that are treating these patients.
Abanye oyo kasoni bana nabelaki nakomaki makasi nalamba nakenda zamba nalamba kitoko mpe na bana nanga toza bien tata eloko te makasi na nzoto.
Patients can be treated much closer to where they live.
On a confiance aux patients et c'est bien.
We're on the path to elimination of sleeping sickness.
It's not utopia anymore to be able to do this incredible research in these incredible conditions.
If we bring the right partner together, we can achieve the best science for a very neglected population.
Le fait que c'est d'abord, il rejoint mon rêve. C'est merveilleux. C'est merveilleux.
အဲ့ဒီမှာမင်္ဂလာပွဲရှိအမြတ်တလုပ်ပြရတယ်အမိပြလိုက်လဲတကားထဖွင့်ရပြင်းနေဆိုတော့စကားစီယုံမစီထားတာအဲ့မတက်လာလည်းမသိဘူးဟိုကို့အပေါ်မှာသူရောက်တဲ့အချိန်မှာမှကိုကတည်တယ်တော့ကျွန်တော်လက်ကိုတစ်ဖက်ကလိန်ထားပြီးတော့ဘက်သက်ကအုပ်ထားတော့ကနေမှကျွန်တော်ဆော်ထားကျွန်တော်ပြောတယ်တိတ်နေတယ်တိတ်မနေဘူးဆိုရင်တဲ့နင့်ကိုတတ်မယ်တဲ့အဲ့အတောင်ကျွန်တော်စဉ်းစားရင်ကျွန်တော်ဦးလေးဖြစ်နေတယ်ဒီလိုဖြစ်ဆိုတော့သူ့မိမသူပြောပြပြီးသားသူ့မိမလည်းတည်တယ်သူ့မိမလာရင်ကျွန်တော်ပတ်စံ1000လာပေးသွားသူ့မိမတော့ပြောနင့်မကိုဝင်ရှိနေနင့်ကိုနေတည်လားတဲ့အာနင့်အခုငါကိုဝင်တော့ဖြတ်ပြီးမှလိုက်ခဲဆိုကျမလည်းရုပ်ရက်ဆိုတော့သွေးပူသွားကျမလည်းထလိုက်သွားကိုလုံးဖြစ်တဲ့အိမ်ရောက်ရောသူဆေးလေးတော့ယူလိုက်တယ်ဟိုကျမမင်းမကူတယ်သူထဲလဲကိုကပြတ်ကြမလို့ဖြစ်ပြီးတော့အမပြတ်ကြတဲ့ဒုက္ခရောက်ခဲ့တာအဲ့တော့ကျမတော့အရှင်းနဲ့ဒါပေမဲ့ကျမကိုချင်းစာစိတ်မရှိဘူး။သူကဘယ်လိုပြောလဲသူရဲ့ယောက်ျားကြည့်ပြပါတဲ့။ဒါခက်ရေစေးရုံမှာ3လတိတိကျမနေခဲ့ရတယ်။ကလေးမွေးပြီဆိုလဲကျမစာစင်ဟာကိုတတ်တယ်ဟုတ်ပဲ။ဒါပေမဲ့ကိုတားမျက်နှာမြင်ရဆိုတော့ကိုအဲ့လိုမျိုးစိတ်တင်းတော့ပြန်နေရတာပေါ့လေ။အမေဒီပတ်ဝန်းကျင်မှာပြန်လာနေကြသူများတွေပြောတာပေါ့နော်ရှေ့အော်လေဟာကန်ချလိုက်ပဲလားလက်ဝါးစံတစ်ဖက်တီးမှမြည်တာတစ်ဖက်တည်းနဲ့မြည်ကိုချင်းမစားဘူးပြောကြတယ်ကိုကကရကရှင်ကိုပြောတာသူတို့မယုံဘူးကျမနဲ့သူဟိုထောင်ကြမှာကျမမျက်စိရှိမှကြားမှာကျမကျေနပ်မှာဘာလို့အမှုတလောက်အေးနေဆိုတော့ကျမတို့မသိဘူးသူတို့အမှုတွေအများကြီးရှိတယ်အဲ့ဒီအမှုလည်းသူတို့မှအရှုံးဆိုတာလည်းမရှိခဲ့ဘူး။ဘာကြောင့်လဲဆိုတော့ငင်းချင်းရေးဆိုမဲ့ပြစ်ခတ်ရစေးပဲချိတာလေလူတွေကဟိုအမှန်တရားပဲမရက်တည်မဲ့ဥပဒေဆိုအမှန်တရားပဲရက်တည်နေမှာပါ။ကျမသားကြီးလိုက်သူများတဲ့မတိုင်တော့သူများနဲ့တန်းသူပြန်ကျမထားဖို့အတွက်ကျမစဉ်းစားထားတယ်
We tend to think about ourselves as humans, but this is only partly true. We are composed of trillions of human cells, but we are also made up of trillions of bacteria. These bacteria are part of us. They cover our entire skin and guts. Bacteria help us digest the food that we eat and protect us from intruders. But some bacteria have the potential to be harmful, causing diseases that risk human life and bring about suffering. So humans discovered antibiotics, and for a time, it was good. Antibiotics are produced by fungi and bacteria in nature, and were adapted by humans to be used as a medicine. Antibiotics are unlike most other medicines. They do not affect the activity of human cells. When exposed to antibiotics, only the bacteria die, while the human cells remain unharmed and the disease is cured. Antibiotics made once deadly diseases as harmless as having a cold. They have enabled many of the improvements in modern medicine, such as safe invasive surgeries and transplants. But look, some bacteria survived the antibiotic treatment. How did that happen? Let's look back. In the very beginning, even before the antibiotic exposure, some bacteria were already different. These bacteria had a resistance gene that protected the bacteria from the antibiotic. So, when the antibiotic was introduced, it did not kill the bacteria that had this gene. Instead, they survived. This is what we call antibiotic resistance, the resistance of some bacteria to antibiotics. But where did this resistance gene come from? How was this resistance gene there, even before the bacteria were exposed to antibiotics? Each time bacteria divide, their DNA undergoes random mutations. Most of these mutations are neutral or unrelated to antibiotics at all. But very rarely, one of these mutations can accidentally result in a resistance gene. Bacteria can also swap genes between themselves. Most of the time, these genes are not related to antibiotics at all. But very rarely, bacteria swap a resistance gene. Even though it is random and happens very rarely, because there are so many bacteria in the world, and because they divide so fast, every hour or less, for each antibiotic we create, there is already a resistance gene out there. What's more, because bacteria swap genes so frequently, this resistance gene can reach by chance disease-causing bacteria, making these diseases much harder to cure. These resistance genes appear and spread randomly, but each time we use antibiotics, we make these rare random events much more significant. The antibiotic kills most of the sensitive bacteria, leaving the resistant bacteria to survive and multiply, so their proportions in the population increase. This is what we call evolution of antibiotic resistance. These resistant bacteria can easily spread in the environment. So each time humans use antibiotics, resistant strains become more and more prevalent everywhere. How can we change this? We can use our growing knowledge about bacteria to make new drugs. These drugs could, for example, prevent harmful bacteria from causing a disease, but without killing them. So even when resistance to the drug appears, the resistant bacteria will not have an advantage compared to the sensitive ones, because all bacteria would have similar chances to survive and multiply. So the proportions of the drug-resistant bacteria will remain low. But what can we do now? We need to change the way we use antibiotics to limit their use to only when it is absolutely needed and in a minimal amount, so we can slow down the rise of resistant bacteria until new discoveries will come.
América tiene diabetes desde el año con 7 meses. Fue diagnosticada con 598 de azúcar en un chequeo rápido de glucosa porque acudimos de emergencia a un médico particular y de ahí fue trasladada en ambulancia a centro médico, un hospital de tercer nivel.
Yo no tengo un recuerdo de una vida sin diabetes. Cuando yo tenía 2 años, 3 meses, fue un 14 de marzo del 2003. Yo inicié con una gripa y de ahí empecé mal, no comía.
Alexis ya tenía más de 600 de azúcar y pues nos lo recibieron de urgencia.
Cuando regresó la doctora, ella nos dijo que sí, que el diagnóstico era diabetes, que nos daba 72 horas si el niño respondía o no.
Pensé que se nos iba a ir.
Lo único que yo sabía sobre la diabetes era que era una enfermedad de adultos. Entonces para mí era muy difícil aceptar que mi hija con años 7 meses la tuviera.
La diabetes tipo 1 es una enfermedad autoinmune que se presenta principalmente en niños o jóvenes. No quiere decir que no se pueda presentar en edades adultas y desafortunadamente no tiene cura. En México, las personas que viven con diabetes tienen grandes retos.
Es toda la vida estar comprando tu insulina, tus jeringas, tus tiras reactivas.
Helmsley Charitable Trust is a global philanthropy focused largely on health. We work in partnership with an international NGO called Life for a Child, and they work in over 40 countries. In Guadalajara, they partner with the Mexican Diabetes Association.
Afortunadamente tenemos el programa de Life for a Child que apoya a estas familias de bajos recursos con tirillas para estarse midiendo la glucosa, con medidores, con lancetas.
Type 1 diabetes is very difficult to diagnose, especially in low and middle income countries where you also have a high burden of communicable diseases.
En la diabetes tipo 1 es necesario administrar insulina y checarse sus niveles de glucosa varias veces al día.
En total serían 5 inyecciones al día aproximadamente, dependiendo cómo ande mi azúcar. Son cosas con las que tengo que vivir diariamente. Y si hay aceptación a lo que tienes que hacer para estar bien contigo mismo, pues siento que no lo ves de una mala manera.
Todos mis juguetes tienen diabetes. Butch es mi peluche favorito en todo el mundo porque tiene los lugares donde se tienen que inyectar. Juego a que lo inyecto.
Tener diabetes no es culpa de nadie, pero la gente piensa que nosotros somos, yo creo que los principales causantes de la diabetes en nuestra hija. ¿Qué hiciste? ¿Qué le diste? ¿Tomabas mucha coca? ¿Le dabas muchos dulces? Hay mucha ignorancia.
The conversation around noncommunicable diseases has largely revolved around preventing these diseases and about changing your habits. But really, for autoimmune diseases like type 1, there is no way to prevent them.
El impacto que ha tenido en mi familia la diabetes, siento que ha sido único. Mi hermano todo el tiempo me pregunta, ¿cómo estás? ¿Te sientes bien? Mi hermana estudia nutrición y después hace su diplomado en educador en diabetes. Y con mis papás son mis héroes sin ellos no sé si seguiría vivo.
Yo hoy en día ya no tengo miedo porque mi hijo ha aprendido a cuidarse. Corre, brinca, salta, juega fútbol. Estoy feliz porque mi hijo está sano.
Mi hija me da esperanza. Verla sonreír. Ella es feliz, ella cree que todo lo bonito que le pasa en su vida es la diabetes. Los únicos límites que vas a tener en tu vida son los que tú te crees.